Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
So welcome, everyone, for today's podcast session at CoROM. Today's topic is back to the cardiovascular emergencies, and today we will talk about pulmonary embolism, discuss the pathophysiology background, and I will show you or tell you my latest patient with PE, the outcome, and also mention some tips and tricks how to evaluate a PE at the field in austere conditions and how to handle it. Okay, so pulmonary embolism, you all well know what is the pathophysiology, what is happening. So there's a thrombus or an emboli or more thrombus emboli within the pulmonary arterial arch. And basically these clots are closing an occlusion, total or subtotal occlusion in the main branch or in the side branches. If the patient is lucky, it's not a total or subtotal occlusion of a large branch. Rather, the affected arteries are the distal, smaller arteries. The survival outcome is better if it's a smaller PE. You all well know this. The background is a lot, so it's a big slice of the internal medicine handbook. It could be impaired hemostasis. It could be a thrombophilia when the blood has a tendency to clot earlier than usual. It could be an immobilized patient after a fracture or after an OP. It could be oncology patients who have a tendency to have thromboembolic complications. It could be a heart infarct. It could be COVID. So it's extremely large range of pathophysiology behind. And PE is really, unfortunately, common, and more PE are presented than detected. So the smaller ones in the side branches, if there's no hemodynamic compliance, then sometimes they are unrecognized. And if a patient has a CT scan, a chest CT, later on for any reason or for COVID, whatever reason, sometimes, quite often, the radiologist describes that there is a sign of chronic PE in the little side branches in the pulmonary arch. So in the acute scenario, when the PE is happening, most of the patients have dyspnea. Some of them have hemoptysis. Hemoptysis is written in the books. In clinics, it's not that frequent as a leading symptom. Dyspnea, tachycardia, some chest discomfort or chest pain, chest sensation. These three are the major leading clinical symptoms. Most of the patients are, at one point, they reach the cardiology department. A quick ultrasound could be a point of care. It could be a fast or focused ultrasound, shows some kind of right heart failure or right heart dysfunction. That's the better word. So the clinical symptoms and signs are quite easy to recognize, and with your physical exam, with blood pressure measurement, saturation, and if you have an ECG on hand or a portable device or a device attachable for a mobile, you could get tons of information to rule in or to rule out the patient as a possible PE. Let me discuss my recent patient, who is a 62 years old gentleman. He works as a mechaniker and as an engineer, and he works quite a lot at field, so some physical work as well. He's fit and well. He takes an ACE inhibitor to treat his mild hypertension. The story is going back to February, so a couple of months ago, when he started to experience quite bad fatigue at the end of the day. So he experienced that he can't handle the amount of physical work as he used to do it before. He thought it's just some spring tiredness or whatever it could be. So he didn't deal with it a lot. And after a couple of weeks, it got even worse. Severe tiredness, fatigue during the day. So he just went to the GP, and a blood sample was taken, and the result showed hypocytoanemia, which was not really severe, but there was an anemia and some slightly elevated liver enzymes. That was all, and the GP was quite thorough, and he also noted that he has some change in the pattern of his stool. So somehow the diagnosis took a step towards the gastrointestinal tract, and he was offered a gastric ultrasound. So he had an ultrasound, and on the ultrasound, unfortunately, very alarming results came. So he had some strange tissue at the site of gastric system at the duodenal part. So something was unfortunately really suggestive of a tissue which just does not belong there. So it could be a cancer. And really quickly, within a week, a CT scan was organized, which showed the sad diagnosis that this is a gastric cancer. Staging was prepared, and they were waiting for other results he had also a gastroscopy, some tissue sample, histology, whatever, and in the end, unfortunately, it was in inoperable stage, because he also had some metastasis in lymph nodes all over the chest. So it just came out of the blue, and it was really shocking for him and for the whole family. This was the case, the beginning of the case. In general, he was still in a good physical condition, and he was resting at home. He was offered an adjuvant chemotherapy to see that whether after the chemotherapy some surgery, palliative surgery, could be performed. And one day in the morning, he woke up with a really severe dyspnea. The ambulance took him to the nearest hospital, and the emergency department diagnosed the pulmonary embolism, subtotal occlusion. So in the left main branch of the pulmonary artery. He was still hemodynamically stable, and so he was hospitalized, and there was a hard decision whether to do a complete thrombolysis or just to put him on heparins and hope that some part of this thrombus could dissolve. So I haven't mentioned that, of course, he had some gastrointestinal bleeding. He had some black stool. Those tissue parts, those cancer parts were a bit bleeding within the gastric part. So an onco team decided not to give the thrombolysis, and because of the severe risk of a severe bleeding in the gastric. So he was given heparin and really closely observed. And really fortunately, he survived this large pulmonary embolism. Later on, he also suffered a COVID infection. He obtained it during the hospitalization, and he was really vulnerable to obtain a COVID. He had mild symptoms with the COVID as well. He were vaccinated 3 times with the mRNA vaccine, and unfortunately, a couple of weeks later, he died. So after the pulmonary embolism, his status deteriorated a lot, and this really aggressive gastric ulcer just took over him. So this was my last PE case, but I'm pretty sure that those you guys are working at emergency departments, cardiology departments in the ambulance, daily, many patients could come with some signs of PE. And again, I'm saying that PE, pulmonary embolism, is underdiagnosed, so more cases are happening than the CT scans are recording. And of course, COVID walks hand in hand with pulmonary embolism, as we've just seen during the pandemic. And the winter is coming. Some upwaves in COVID could come, and also the influenza viruses are attacking. So I assume that there would be a bit of increase in PE as well. Okay, let me discuss what are those clinical points, your clinical findings that could help you to suggest that this is a PE. So if you are at the field in a remote condition, without the help of a CT scan, without the help of an ultrasound, you might have a pocket ultrasound with you. It's not so easy to evaluate the right ventricle. That's always a bit tricky. It's not a good view with the ultrasound. So if you are just at the field, bare hands, what do you have to rule in or rule out PE? Of course, the symptoms. And then we have some very well established score systems to use in the emergency situations. One is the Welsh score, and the other is the Geneva score system to evaluate the risk of a pulmonary embolism. So these are old generated scores. So it's good to remember that they are not tailored individually to the patient. So, and most of the patients, they don't know these score systems. So let you have those inner voices when the score system is not fitting, but you have some hints, and the score is not matching a high risk for PE, but you still suggest that this is PE, then trust yourself. Let me discuss the score systems. So the Welsh score system. If there's clinical sign of a deep vein thrombosis, you have the swollen leg, you have some pain, that's a high score. If the alternative diagnosis is less likely than pulmonary embolism, then that scores highly. So it's again, when you are in the field in remote conditions, this point would not really be helpful. Then the heart rate, as I just mentioned, I've never seen a patient with PE without tachycardia. So if it's a PE, which is hemodynamically affecting the patient will be tachycardic. If there's an immobilization or surgery 4 weeks previous to the acute happening, then that scores. If there's a previous venous thromboembolism, if there's hemoptysis, I mentioned it in the beginning, that's not so frequent, and active cancer also gives 1 point. The deep vein thrombosis is 3 points. So cancer is not really weighted in this kind of system. And in my clinical practice, I've also seen that really, really large percentage of patients suffering from active cancer, sometime on their route of treatment and healing, at some point they suffer a PE. The reason behind is that the cancer itself generates a prothrombotic state of the blood, and the medications they receive, the chemotherapy, the radiotherapy, they make the patient prone to a thromboembolism. Many researchers are going in the background. What is the reason? Are they the platelets? Is it the liver? What is happening? And how to catch these increased state of thrombotic state of the blood. So definitely I would give a higher score for active cancer in this score system. And but still the negative predictive value of the Welsh score is very good. So if the patient is not scoring 4 or more, then the possibility of PE is quite low. So if you can just walk through these, and for these you only need a patient to tell you, or a relative to tell you what was going on in recently, what is the history, then you can get a really good assumption, really good suggestion whether it's a PE or not. The other score system is the Geneva one, which is a bit more specific and includes more points and a bit more diversified. It includes age, over 65, higher risk, includes a previous deep vein thrombosis or PE, includes a surgery or fracture within 1 month, includes an active malignant condition, and it gives 2 points for an active malignant condition. So it rates the cancer a bit, weighs a bit more than the VAS score. Then the unilateral lower limb pain is also included, hemoptysis then, and it's really fascinating for me that it has heart rate and it has 2 ranges. So it has one heart rate between 75 to 94, which is within the normal, but it could say that it's a high normal heart rate, so definitely not bradycardia, or the heart rate is not 60 or below. And it has another point where it says the heart rate is above 95. So it's above 95, patient is tachycardic. It scores more than the range between 75 and 94. Okay, so tachycardia, really high possibility of PE with all the others. And if there's pain on deep palpation or lower limb on unilateral edema, so the complete signs of the deep vein thrombosis, that's the highest score. And if your patient score is 11 or more in this one, then that's a high probability PE. So I would suggest that have these score systems with you and do a quick evaluation. And if your clinical suggestions are turning towards PE, then handle it as a PE. If you have a thrombolytic drug at your hands, if you are lucky or your patients are lucky enough to have one in the field, and there's a high probability of PE, and the patient is hemodynamically unstable, then I would suggest to do the thrombolysis in the field in oyster conditions as well, because that's the only chance for your patient to survive. I would not thrombolyze someone who is hemodynamically stable. If the patient is deteriorating during your observation, I will also say that step forward, step towards the thrombolysis. I hope that many of you could make this decision, because that would mean that you have the drug at hand. It's quite expensive, not really available in ambulance cars, but hopefully at some regions, or you have a pretty well-equipped oyster emergency pack and you can bring a thrombolytic drug and do so. Today, we discussed the pathology, we discussed the case, and I just gave you this 2 score system, the Wells score and the Geneva score system, to I wouldn't say to learn, but to have in your pocket and go through it if you have a patient who possibly has a PE. If the patient is lucky, then it's not a really huge, not a total or subtotal, or not affecting the large branches. Most of the patient, by the way, they suffer long-term impairment as well if they survive a PE, because the right ventricle suffers a lot during the PE. So it could be long-term cardiac failure, heart failure. It can also severely damage the lungs if it's an infarcted lung during the pulmonary embolism, which happens often. Then pulmonary complications are also occur. So once a PE happened, it's a multidisciplinary approach after to get to deeply dig to the main reason, internal medicine, cardiology, etc., to avoid a second PE. And also, I would like to outline that if you have a patient with an active cancer, early think about the thromboembolic complications, because they happen really, really often, and the primary prevention is extremely important in an oncology patient not to have a thromboembolic event, and also thromboembolic events are still underdiagnosed. So these were the take-home messages. So I hope that this podcast today gave you a good summary on PE and how to detect quickly in the field. And I wish you all the best, and for your patients as well. Keep in track with CoROMcasts. Talk to you the next time. Bye.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is CoROM, CoROM, corom.org.